For those of you I don't know, my name is Joe Shaker. I'm an endocrinologist at the Medical College of Wisconsin. My practice is all bone and mineral. And okay, I have no conflicts of interest other than my opinion. She's a 76-year-old woman who I saw. She'd been on denosumab since 2018. She had a right wrist fracture in the 1990s. But shortly before I saw her, she had a pelvic insufficiency fracture. You know what? That's while skiing is an error. I think I just transposed that twice. Definitely wasn't skiing at this point. And then had another pelvic fracture and an L5 vertebral fracture very shortly thereafter. Her past history was significant for a few short bursts of steroids for asthma. She was on calcium and D. She was a diabetic and hypertensive. She had a family history of osteoporosis in her mother. She wasn't a smoker or drinker. She was not grossly Cushingoid. These are her pertinent labs. Her calcium was normal. A PTH was high, but she was vitamin D deficient with a 25D of 17. And this PTH was obtained only a few weeks after denosumab, something known to raise the PTH. She also had some CKD. Her GFR was a little less than 50. So her low D was treated, and before her next denosumab dose, her PTH had normalized. Her urine calcium, not surprisingly low with this degree of CKD. Imaging, her spine x-rays showed no additional fractures. Her bone density is shown here. As you can see, her lowest T-score was at the forearm and was minus 3.1. The spine was not particularly useful due to degenerative changes. And in reviewing her record, she was from the outside. I noticed that a CT scan from 2015 revealed bilateral adenomas. I still haven't been able to get this imaging, but she had another CT scan of her abdomen done in 2022, and it showed this left adrenal mass and this a little bit larger right adrenal mass. Both had Hounsfield units of about minus 10. And she had a PET CT done for another reason, which showed that the larger right adrenal mass did have mild uptake. So here's her 1 milligram DST. As you can see, her ACTH suppressed nicely. Her dexamethasone was appropriate. And her cortisol was 2.3, which is higher than the 1.8, consistent with MACS. So she had severe osteoporosis. I certainly thought MACS could be a contributing factor. I was reluctant to change her to a bisphosphonate with the risk of bone loss after 4 years of DMAB. The data switch study shows transient significant bone loss if you change to teriparatide, so I wouldn't do that. And so I actually suggested addition of teriparatide or abaloparatide for 2 years with ongoing denosumab. As it turns out, she declined this. She just stayed on DMAB. She didn't see Catherine. But later that year, she was diagnosed with squamous cell anal margin cancer and was treated with chemotherapy and radiation. And so really what I wanted Catherine to do was comment on surgery or medical treatment in these patients, and in the patient with bilateral adrenal masses, if you're going to do surgery, what you would do.
Sure. So for, I guess, the first part, surgical and medical treatment of MACS and kind of elderly osteoporosis patients. So again, there's kind of limited longitudinal data with some showing that maybe surgery would improve some of these cortisol-mediated comorbidities. Generally, in patients who have, a couple of these comorbidities that may be mediated or exacerbated by cortisol excess, and they're a decent surgical candidate, surgery is generally my preference to medical treatment. I think if they're not a good surgical candidate, they're usually not a good medical candidate for medications, at least, that lower cortisol. So medications that lower cortisol are associated with, a lot of side effects, can lead to adrenal insufficiency, and I wouldn't really favor using them in elderly patients. I think the counterpoint to patients who don't have surgery for cortisol excess is that they should be kind of treated aggressively with medical treatment for specifically the comorbidity. So like Joe, for example, recommending kind of aggressive treatment for osteoporosis. And there's really have been no kind of like real head-to-head studies looking at adrenalectomy versus just aggressive treatment of comorbidities in terms of what happens with outcomes. The other question about bilateral adrenal nodules. So cortisol excess tends to kind of correlate with the size of adrenal nodules, meaning that bigger adrenal nodules are more likely to produce cortisol excess than a smaller one. So in people with bilateral adrenal nodules, and theoretically, both of them could be producing cortisol, but it's probably coming from the larger side. The other thing maybe specific to this case is that hormonally active adrenal nodules can have a little bit of FDG uptake. So studies show that they have more FDG uptake compared to non-functioning adrenal nodules. So in her case, it's probably, if I was to recommend surgery or talk about surgery with her, it would probably be a right adrenalectomy.
Thank you. Thanks, Catherine. Does anybody have any questions or comments before we go on to the next?
I have a question regarding your case. So you said at some point that you recommended to add, teriparatide to the Prolia. How do you do that in clinical practice? I know that studies show that there's improvement in bone density, but how do you do that in clinical practice? Do you give them samples, or have you ever got that approved along with?
I have gotten it approved, but it's not easy. Your question is a really good one. I fight for it, but we don't have any samples in our clinics. So there's no way to do that.
So tell me who approves it, Blue Cross? Like just one.
Well, I can't. I've had it approved a couple times, and I don't remember the insurance companies.
All right.
I'm sure Neil's done it too. Have you been able to get this approved sometimes?
Yeah, they're usually the patients that you want to wrap in bubble wrap.
Yeah.
And to that end, Joe, I wonder if you did Hounsfield unit measurement on that CT, because with pelvic fractures and vertebral fractures, I bet her spine HUs were awful, and that might have been additional information to push her toward an anabolic, perhaps Romo.
So I'm sure I did them. I didn't include it here, and I can't remember. But yeah, I'm sure I did it. And I think it's a good point. The problem with Romo, I mean, I don't know any data on Romo with DMAB. The data on Romo after DMAB is that they don't seem to lose bone, but the anabolic effect is extremely blunted, more so than after bisphosphonates. So, I don't know what to say about it. I think it's a question mark. But the question about trying to get it approved, I have been successful, but I have also been unsuccessful more frequently. If that's the good answer.
Yeah, that's a good answer. I have had some patients switch to romosozumab, and like you said, I don't see, in those extreme cases what do you do, especially Medicare patients, and I don't see a dramatic change in the bone density.
Yeah.